Hi, welcome back to IU Radiology Case of the Day. My name is Tim Tsai, and I'm a fourth-year resident at the Indiana University School of Medicine. Today, we've got an interesting abdomen case. I'd like to give a shout-out and thanks to Dr. Swenson for his help, and of course to Dr. Kuntz for organizing the entire Case of the Day initiative. I'd like to take a moment to emphasize that all of the content in this presentation has been de-identified to protect patient privacy. For the history on this case, we have a patient with lupus presenting with elevated transaminases and alkaline phosphatase. We have a series of images and a number of findings for this case. At the top left is an oblique coronal haste thick slab image through the upper abdomen, followed by a coronal haste. At the top right is the axial T1 pre-contrast image. Along the bottom row are images taken during the arterial, portal venous, and 5-minute delayed phases. Again, this patient has a history of lupus, is presenting with elevated transaminases and alkaline phosphatase. Take a moment to look at the images. Next, I've made a little cine of the portal venous phase imaging, which you may find helpful for this case. Now that you've seen the images, what are the findings? What's your differential? And what is your diagnosis? Let's go through the images and findings. On the oblique coronal haste thick slabs, we see that there is intra- and extrahepatic biliary ductal dilation with smooth distal tapering. These are also present on the coronal haste images. There are also multiple intrahepatic bile duct strictures. There is a tangle of vessels at the porta hepatis, reflective of cavernous transformation. The spleen is enlarged and contains innumerable punctate foci of low-signal lesions reflective of gamma-antibodies and portal hypertension. The large vessels at the porta hepatis actually encircle the bile ducts. This is better depicted on the cine loop. The portal hypertension, of course, is secondary to chronic thrombosis of the portal vein. On the arterial, portal venous, and delayed images, the structures surrounding the bile ducts are indeed venous in origin. There are no suspicious masses or washout lesions. The liver capsule is notably smooth and does not appear to be overtly cirrhotic. Dilated gallbladder wall varices are also present. The patient's elevated alkaline phosphatase and transaminases here is secondary to portal biliopathy. Portal biliopathy refers to biliary obstruction secondary to enlarged collateral veins following chronic portal vein occlusion and cavernous transformation. The enlarged veins cause extrinsic compression upon the bile ducts. This condition most commonly occurs in non-cirrhotic patients with hypercoagulable states, rather than patients with cirrhosis. This is reflective of differences in the development of collateral flow. Portal biliopathy is generally divided into 3 types: varicoid, fibrotic, and mixed. Varicoid portal biliopathy refers to the mass effect of bulky, sometimes mass-like pericholedochal veins compressing the bile ducts. Fibrotic biliopathy results from inflammatory and ischemic changes of smaller intramural collaterals and appear as narrowed, thickened, and densely enhancing bile ducts. A mixture of the two can also occur. Portal biliopathy is often asymptomatic. However, like any obstructive biliary process, elevated liver enzymes, jaundice, cholangitis, and choledocholithiasis can occur. Hemophilia is also a possible complication. Portal biliopathy is slowly progressive, and patients with complications may benefit from balloon dilatation and stent placement across strictures. The differential of portal biliopathy importantly includes malignancy, such as cholangiocarcinoma or lymphoma. This necessitates careful scrutiny for an actual mass with suspicious features, such as peripheral and central gradual enhancement in cholangiocarcinoma or bulky adenopathy in lymphoma. Sclerosing cholangitis on MRCP may also have a similar appearance of the bile ducts. However, the overt appearance and expected behavior of dilated collateral vessels distinguishes portal biliopathy from these other diagnoses. Choledocholithiasis can also cause biliary ductal dilatation and can occur concomitantly with portal biliopathy, so again, careful scrutiny is in order. For more reading about portal vein thrombosis and its spectrum of disease, I'd like to recommend this paper. To sum it all up for portal biliopathy, the key feature is the fact that the biliary obstruction is from engorged collateral veins in the setting of chronic portal vein occlusion and cavernous transformation. A unique clinical feature of many patients is the fact that they are not cirrhotic and have hypercoagulable states. Be sure to keep a careful eye out for things suspicious for malignancy. It's also important to keep an eye out for complications, including cholangitis and choledocholithiasis. So as always, thanks for tuning in to the IU Radiology Case of the Day. You can follow along on Twitter at NACoons, and you can check out our complete collection of Case of the Day materials at the link below. Thanks so much, and have a great day.